So with this, my name is Dr. Nancy Chugh. I am the Director Marketing for International Business at Translumina. With me, I have Dr. Georgie Thomas. Last minute change, Dr. Alfonso, because of unfortunate reasons with family urgency, will not be attending the program. So we requested Dr. Georgie Thomas to take up the moderation for today's program, and we are thankful to him for taking it up. So just to give you a brief background about Translumina as an organization, so we are an Indo-German company. We have manufacturing facilities based in India and Netherlands and Germany. We have six manufacturing facilities. We are completely into a manufacturing line of drug-eluting stents and DCB portfolio along with PTCA balloon portfolio. In India, we are clear number 2 position in interventional cardiology after Abbott. And it brings out to a market leader position when it comes to interventional cardiology and bringing new innovative technologies in the market. And we have a very strong collaboration for our technical and for our R&D insights with our German Heart Center team. We have Professor Adnan Kasrati also joining us in this program. We have 2 landmark DES technologies, which are Yukon Technologies and Vivo ESA, which has the longest 10 years data of safety and efficacy studied in a randomized control trial from ESA Test 4 and ESA Test 5. And we will have many more insightful discussions around DCB today, which is around Protege, paclitaxel coated balloon. From Blue Medical, we acquired this company in 23 in July. After this acquisition, we have really done well creating a market landscape for DCBs. And we have the experts today in the program who will bring many more insightful discussions around the real world use of DCB. So with this, I would like to introduce Dr. Georgie Thomas. He's the HOD, Burjeel Hospital, working in Burjeel Hospital in UAE. He carries a huge experience in managing complex interventions, specialized in CTOs and in complex subset. So he has a vast experience of treating the complex subset of patients. And Dr. Georgie Thomas would take up the moderation session today, would introduce all our faculty for today's program, and he would be taking up the questions from the participants, and we hope that we will have a great success in the program. Thank you so much.
Thank you, Nancy. It falls on me to moderate the session today. Good evening to all of you. Good evening, dear chairpersons, dear speakers, and panelists. Today evening, it's a matter of honor to just chair the session along with the rest of these people who've joined us today. We have big names with us, with Professor Adnan Kastrati and Professor Florence Tsutsuli, who are going to be the chairpersons for this session. Briefly, Dr. Kastrati needs no introduction. He's one of our very familiar, very well-known cardiologists that we know. Is the director of ISAR Research Center in Germany. Was previously the head of interventional cardiology at the German Heart Center, Munich, and is the chief physician and the deputy director of the cardiovascular disease clinic. He's well renowned in the field for his contributions in percutaneous coronary intervention. We will be looking to hear from his insights on drug-coated balloons today. Professor Tsutsuli is also an interventional cardiologist based in Lucerne, Switzerland, with almost more than 20 years of experience. He serves as the head of Department of Cardiology at the Heart Center Lucerne and is also the director of Cardiac Center in Lucerne. Dr. Tsutsuli specializes in complex coronary interventions with a focus on treating highly calcified lesions, intravascular imaging, and the use of the drug-coated balloons in advanced lesions. We also have an expert panel. I will introduce the speakers before they start speaking. The expert panel, we're joined by Dr. Nguyen Thai, who is the head of department of the Interventional Cardiology Department in Vietnam National Heart Institute at Bach Mai Hospital, Vietnam. Dr. Khalid Tamam, who is an interventional cardiologist and director of invasive cardiology at International Medical Center Jeddah in Saudi Arabia, who also heads the CTO programs in the Al Salam and Dar Al Fuad hospitals, and also in Cairo and Egypt. So he works in 2 countries. Dr. Srinivas Reddy who is the founder and managing director of cardiology department at Mahatma Gandhi Hospital at the Palnadu region. Dr. Samir Dani, who is also a very well-renowned expert in the interventional cardiology field from India, works at the Apollo CBHF Hospital in Ahmedabad, India. And Pramod Kumar, Dr. Pramod Kumar, who's also the director and head of department at Medanta Hospital in Patna in India. So without wasting much time, I would invite the first speaker, Professor Tsutsuli, to go ahead and tell us what he has for today. Dr. Tsutsuli, it's all yours.
Yeah, thank you so much for the very kind introduction. And of course, it's a great honor to share a really lovely case with you. And as you saw in the agenda, I have almost 30 minutes to share this case, which is quite a lot of time for one case. But it might not take 30 minutes, and I will try to do it in a very systematic fashion. Now, let me start with the patient. This is a 77-year-old gentleman who is symptomatic with angina. So he has known atrial fibrillation and actually closed his left atrial appendage 3 years ago. And usually, as you know, these patients with left atrial appendage occlusion in the past, they are usually multimorbid, but this patient actually is still quite robust. He has a diabetes on insulin, he has hypertension, he's, as I mentioned, a high bleeding risk patient. And now, after we diagnosed him with coronary disease and with, as you will see, left anterior descending artery disease, he actually refused CABG. I think, in fairness, he would have been a very good candidate anatomically for CABG, but the patient did not want to hear about that. Here you can see the device, and you can see that LED. This angiogram was performed about 1 week before the procedure was done. As you can see, the patient has mainly LAD disease. I'm not showing here the right artery, which is not very large and actually not significantly stenosed. He has diffuse sclerosis also on the circumflex, but his main problem, as you can see, is this really long disease from proximal to distal with the LAD. So that's our main challenge. Now, as you will see now from the angiographic picture, you will see it's a long lesion. It's maybe a calcified lesion. I can go back once and then show it the LED again. So it might be a little bit calcified, but of course, it's always a bit difficult to tell this from the angiography alone. I'm sure that this is a surely treatable lesion with stents. And maybe if it's a lesion we could treat with drug-coated balloons. Now, maybe the first point which needs to be discussed, why would I even think of using a drug-coated balloon in a 77-year-old gentleman with in this situation? Well, I think the reason are two, which are very important reasons. One reason is, of course, as I mentioned, this is a high bleeding risk patient. So I think to not implant a stent, a permanent implant in a high bleeding risk patient with previous left atrial appendage occlusion is probably a good thing to do. But even more important, I think this patient is with diabetes and he's on insulin and he's refusing CABG. That's why I mentioned I would have sent him actually for a minimally invasive left mammary to LED bypass, but the patient did not want this. But if I don't go for bypass, then to end up having 70 or so millimeters of stent in this LED, yeah, that could work. It's a large vessel that could work. But if it doesn't work, then I really have a problem. Then I'm forced to send him for CABG because then the restenosis could be difficult to treat in this setting. Now, I think what is important to think, especially in the learning phase, and I'm now speaking to those who are not super experienced with drug-coated balloons, but who are just about to start. You will hear a lot of people saying, well, you don't need imaging for DCB treatment. It's true, you don't need imaging for DCB treatment, but I think in the learning phase, and as you adopt with therapy, knowing what you are doing, and knowing how to do it, and you know, to really learn also from your own experience, imaging helps a lot. It did help me a lot. Now, the main question, if you go with imaging, and I think you can, if you speak to an IVUS specialist, he will maybe give you more arguments for IVUS, but I'm not an IVUS guy, I'm an OCT guy. So I think the main question for the OCT in this setting is first morphology. Is this a really just a calcified vessel? Is it fibrosis? Is it soft or ruptured plaque? Because if it's ruptured plaque, then you will behave differently. You will choose different material than if it's heavily calcified calcium ring. Now, even more important than morphology is the size of the lumen and the size of the vessel. And here there's a fundamental difference. If you stent, then you size by the vessel size. So you will choose big balloons because you don't care if you dissect. The bigger the dissection, the more easy then usually becomes for you to just put a stent and then cover this dissection. But if you go with drug-coated balloons, you like a little bit of dissections, but you don't want big dissections which force you to implant stents. And dissections is really heavily related to the balloon size. Also to balloon pressure, but much more to balloon size. So I think you will want to size rather more conservatively, in my opinion. So then you don't cause a big dissection, and then you are not forced to put a stent. And then the third point is also very important, is assessing the final result. Do you have luminal gain? You can go also angiographically for this, and you can go by the consensus recommendations, which say you aim for less than 30% diameter stenosis. But I think it's even better to have minimal luminal area, because that will give you a bit of a better idea, and we'll speak about that. But then also even more important than that is, do you have a dissection which is hanging the lumen? Do you have an intramural hematoma? Because if you have an intramural hematoma, then you might want to do some more work or stent, because then otherwise this vessel can occlude. Now, let's do the OCT image. Here, you will see we are going now, and I will let it run twice. We are going now from the proximal part of the LAD to the distal part of the LAD. And as you can see, some parts of the vessel are not that diseased. Some part of the vessel are very diseased. And there is different morphologies. And this is normal, because very often you don't only have calcium. You will have a little bit of calcium, a little bit of fibrosis, a little bit of soft plaque, and this will be a mixed bag. So I will have a look again. But of course, you cannot just treat the proximal and then the mid part and this part with 3 short stents. I think if you start, you are in this setting forced to treat the full length of this vessel. So now, when you have done imaging and then you go for lesion preparation, I think depending on you will have people who have a very simple mindset, and they will say, well, just inflate the balloon. And then, you have a dissection and leave it. I think you should be a bit more targeted, a bit more tailored, because if you do an expensive method like OCT, then you should draw some conclusions from that. So in this case, in a fibrotic lesion, I think cutting balloon is the answer, then followed by an NC balloon. If I have a calcium ring, then you go with open NC or IVL to crack the ring, to gain some lumen, and then you go with an NC balloon. If you have soft plaque, then you don't want to use a cutting balloon. Then you use an NC balloon, and maybe soft plaque are best treated with stents. We don't know. Now, regarding the sizing, I think it's important to size the balloons according to the distal luminal size, to the so-called healthy lumen, which you see distally, not to the healthy vessel size. Because if you go by the vessel, your balloon will always be a bit too big, and you will just have more dissections. So now, what is a good result after DCB treatment? I think nobody knows this question, and there is no data for this. But in our center, we have established a rule of thumb, which works quite well now in our daily life. We go in vessels larger than 3 millimeters, we go by a minimal luminal area of 4 square millimeters. In small vessels, you will go by 3 to 4, sometimes even less than 3. If it's a very small branch, you will not achieve even 3 square millimeters, and that's fine. But I think in a prominent vessel, you aim for 4, and sometimes you end up with 3.5. Now, in this particular patient, you see that there is basically 3 different spots which are very tight. The very proximal spot you see there, this is a fibrocalcific lesion, because you see the calcium with the automatic detection of calcium, but you don't. This calcium is not superficial, so rotablation here would not help you a lot to modify this lesion. So here you need to do something about this calcium to crack it, and then you will also need something for these fibers to cut them. In the mid part, you see there's no calcium, but this is a purely fibrotic lesion. So here, in order to expand, you mainly need the cutting balloon. And in the distal part, again, we have a fibrocalcific lesion. The minimal luminal area in the very distal part, it's 1.77 square millimeter. And then in the mid part, 1.8. I did not do FFR here, but the patient was having angina, and I have a very tight lung disease in the LAD. So I'm not doing FFRs in that patients. This is useless and does not give really any added benefit. Now, how did we proceed in this case? Well, in this case, we proceeded by using, so I was not really, as you can see, this is the distal part. The luminal size is 2.55. The vessel is actually 3.5. This is a large vessel. But I was afraid to use a big 3.0 balloon, cutting balloon from the start, because then I was afraid that I might be dissecting. So I said, let me just go first with a 2.5 cutting balloon. So I sized according to the distal healthy. It's not healthy, as you can see, but still you consider it healthy lumen. And then I went to 20 atmospheres in the distal part. And then I found out that actually for the proximal part, the balloon was too small. So I used the 3.0 cutting balloon in the proximal part. Then in this case, because it was very calcified, I said, let me gain some lumen without stretching the vessel too much. So I used an open NC balloon at 35 atmospheres to just gain lumen with a heavily non-compliant balloon. And then I used two protege balloons, 3.0 by 30 millimeters. And I inflated them at 6 to 8 atmospheres. You will see in all my cases, I don't go with these balloons to very high pressure. Unless you use the Protege NC, which is a non-compliant balloon, the Protege SC and other semi-compliant balloons, they are really semi-compliant balloons. So if you go to in a lesion of this kind, if you go to 14 atmospheres, then you will dissect clearly, because the balloon will just expand where it faces the least resistance. As you can see, this is the result I achieved. And the luminal gain is actually quite nice, angiographically. I don't see a big dissection. I don't see lumen. I don't see contrast hanging there. So this is actually angiographically quite a good result already. So clearly a diameter stenosis less than 30%, I would say, and clearly no flow limiting dissection, very good flow. This is now even a better picture. As you can see, it's a good result. Now, would you achieve a much better lumen with stents? Yes, of course. You will put a 3.5 stent. You will have. Do you need much more lumen? No, you don't need that, because I think you have already treated his angina. Do you know that you will be gaining lumen? Yes, we know that for a fact, because we have now experience about luminal gain. At least, I would say, from the MLA, at least 30% gain within 2 months. You will have that. We have data for that. So I consider this to be a nice result. Now, do we need OCT in this case? Well, in this case, you don't need it anymore, but I had it, so I did it. And now let's have a look at the OCT. Now we are going from the proximal part to the distal part. And for those who are not using intravascular imaging, they might think, well, there's a lot of dissections, I need a lot of stents. No, this is a perfect result. This is a perfect result. This is how it should look like. That's clear. So in the very distal part, we have a very safe landing. So we don't have a dissection which does not have an end, basically, or creates a hematoma. Here you will have some dissections going into the media, but that's fine. The important thing is that our lumen is large. The MLA is about 4.6, 4.7 square millimeters. And we have these dissections of the intima and a bit of the media, and we know this will enlarge. So this is a very good result. Now, if you look at this, then you will see that we have some regions with more dissection, but here we should not touch it. Now, I think if we summarize now for this case, how should we address this? I think one of the important questions is really, do we have a lot of calcium? Because if there's calcium, then you might choose a different way to treat it. So I think if you have imaging, you will know is there calcium, you will know the size, you will know the morphology, and this will make your success rate in the learning phase to finish with a DCB higher than without imaging. If you have a ring, crack it, use OPN or IVL. If you have a nodule, then basically we only have orbital. If it's an uncrossable lesion, and I have a case ready, but I could briefly share it with you, then you will probably go with rotational or orbital atherectomy. If it's deep calcium, then don't do anything with it, ignore and respect it. And if it's superficial calcium or fibrosis, then you go with a cutting balloon. I will remind you of the LUCA meeting, which will find place this April in 3rd or 4th, and Adnan Kastrati is one of the distinguished faculty, and I'm very happy to have him there. Now, I want to show you another case before I conclude. Here you see this is a nice similar LAD, but angiographically you see this is a different animal. It's heavily calcified. It's a heavily calcified LAD, and here I did not consider surgery because I think I could fix this myself. But you will see the balloon is uncrossable. This is a 2-0 semi-compliant balloon, and the balloon does not cross. I wanted to cross the balloon to just do imaging, but then it did not cross. So what I did was here, again, you see the guide is backing up. Now, of course, I could use a guideliner and 3 wires and extra support, whatever, but I felt it's calcium, the balloon does not cross. Let's do some debulking. So I used orbital atherectomy here to debulk. And I did that at 80 and 120,000 RPM. And now you will see the result after the orbital atherectomy. So the lumen has now already enlarged a little bit. It's still no balloons, just after orbital, but it looks good. So I felt, why? I could also treat maybe this lesion with a DCB. So I used a cutting balloon to further expand the lumen, and I achieved a good result. And this was the final result. This is how and I left it without a stent because I felt there's so much calcium, the stent is already there. And I brought this patient back some months later, and that's why I'm sharing this case to just give you an idea with the follow-up. And this is the OCT image of this patient after some months, I think about 3 months. Look at this lumen, beautiful. So heavily calcified lesions can also be treated with drug-coated balloons, provided you do a good lesion preparation and you gain lumen in the acute phase. And the last point I wanted to mention is about the protege, that I've named here a master in crossability, because I think if you treat difficult lesions, then you need a balloon which crosses. Most DCB based on paclitaxel are very stiff and don't cross. They don't go around the corner. But in this case, you can see here through the stent, the protege crossing very easily. You see that? Very, very easily crossing through the stent struts. And then a good result for this side branch. The right distal has a graft. And here again, you see I've stented from the LAD to the diagonal, and now I want to do the DCB on the LAD. And you see that now crossing there is difficult, but here again, you see it crosses easily. And then I did some kissing. So with this, I want to conclude. And I can summarize that, in my opinion, the use of DCB in complex lesions is something we need to do, because that's where we have the best data that stents fail. And I think when we do new things in interventional cardiology, then we should always try to solve a problem. I think the importance of using imaging cannot be underestimated, especially in the starting phase of a program, to just learn from what you're doing and maybe also learn from the mistakes you're doing. Then I believe that heavily calcified lesions are a good target for drug-coated balloon therapy. And last but not least, I think with Protégé, we have now a balloon which is not only a good drug carrier, but it has also a very good crossability, which allows us to treat really difficult lesions which would not be very easily done with other paclitaxel-based drug-coated balloons. And with this, I conclude. Georgie, I think we have a lot of, I made some time up, maybe 5 minutes. So I'm done. Thank you so much.
Thank you so much, Dr. Sassoli. It was an amazing presentation. And of course, you have highlighted the use of imaging more than the procedure. We all need to know what we're doing. We can always inflate a balloon and look at the angiogram and say it looks great. I would not discuss right now, but because for want of time, let's go on with the cases. Those questions can keep coming. We'll keep the questions for the end. I think big fan of Professor Sevket, who's a CTO operator, and it's just an honor to be with him on the same platform. Professor Sevket, it's your turn up next for your case. Professor Sevket Gogolu. Can't hear you, sir. Absolutely cannot hear you.
So before I begin with my speech, I would like to thank the Translumina team for including me to another fantastic event. And thank you, Georgie, for this nice introduction. So I need maybe 1 extra minute that left from Florim. I can use that. It would be of much help for me. So I will be very swift when I'm presenting. As a high volume CTO operator with more than 500 cases last year, I tried to finish all my cases with no stent strategy by using drug releasing balloons, mainly Protege, which is a drug eluting balloon, according to me, rather than a drug coated balloon. The reason why I try so hard to finish with DEB is the need for better solutions than stents. Stent underexpansion, malopposition, stent thrombosis, and restenosis is still a problem, despite the increasing use of IVUS, IVL, atherectomy. And another problem we are facing is the need for long-term dual antiplatelet therapy, which increases the risk of intracranial bleeding and mortality in elderly, frail patients. So the first usage of DCB in the Progress CTO registry was in 2018. Usage of DCB increased from 2000 to 2024 significantly, especially in the last 2 years. The increase is prominent. So these are the scenarios we are using DCB in CTO PCI, especially in instant CTO. It is very, very appealing. However, the latest ECG guidelines changed its recommendation in instant restenosis and states that DES is recommended over DCB for treatment of in DES restenosis. Behind this decision making lies one randomized study and 2 meta-analyses indicating better target vessel revascularization rates at 3 years. The MACE rates are not different between the 2 approaches. I'm strongly against this recommendation. Let me explain why. So imagine this long CTO as an instant restenosis. Who would think upfront stenting such a long lesion, hoping for a moderately better target vessel revascularization at 3 years? Personally, me not. Covering the artery with 2 layers of stents and damaging the artery's vasomotor function further by creating a straight, stiff pipe. What if we have an re-instant restenosis after 2 metal layers? Putting a third stent, is that really the answer? Of course, IVUS interrogation is very important. After IVUS interrogation, long scoring NC balloons and preferably finishing with an NC Protege drug eluting balloon is my default strategy in instant CTO. If I have restenosis in 3 years, again, all options are still available and on the table. What if we have restenosis in an area overlapping 2 metal lesions? What options do we have then? This is putting a third stent. Is that the answer? this is a hell of a case here. And this, we have 2 layers of stents there, and we have restenosis again in this case. I don't care what the guideline is recommending. If I have an instant restenosis, proper intracoronary imaging, searching the underlying cause, prep the lesion accordingly with scoring, cutting balloon, rota, IVL, whatever, and then finishing with DEB or DCB. What one should think twice before treating an instant restenosis with a new stent. We treated this lesion, it had 2 metal layers, and we had a lot of difficulty and run a lot of problems with hemodynamic compromise of the patient. So instant restenosis is not a benign thing. So the other thing where I like the DEB is complex CTO lesions. For example, here we have an LAD osteal CTO, and osteal CTOs are one of my favorites to finish with DEB. And here we had a retrograde approach. I don't want to go into details, but you will see after having a Protege 3.520 3 times, you can use this balloon 3 times, and inflating a balloon in the left main might not be so comfortable for the patient and for you as well as an operator. So, but with this balloon, you can do it 3 times with 30 seconds, and you have still drag on the balloon. So here, for me, this was a very fantastic results. Of course, IVUS interrogation was also a part of our treatment. So this is another case, not only for osteal lesions, I also use it for side branches coming from the inside CTO. This was a very difficult case. We had viable territory at the myocardium, but we had no target vessel. So we were very lucky here. We knuckled into the diagonal, we knuckled into the LAD. Somehow the wire found its way. And here you can see that the diagonal was left dissected and was left with drug-coated balloon after stenting the main vessel. And evidence is piling up regarding DCB in situ PCI. These are the very latest publications indicating no difference between DES and DEB in terms of MACE, TVR, and TLR. I am one of the main investigators of an only DCB approach in CTO PCI. We created a section in the Progress CTO database and transferring our data into the registry. In the middle of 2025, we hope to give you some updated, fresh data. All comers is the population in our study. Simple, complex, ante, retro, it doesn't matter. As long as we have TIMI3 flow after vessel prep, we do everything to finish with a drug-coated balloon or a drug-eluting balloon. Even investment procedures are in our interest to finalize with DEB. So this is another example here. This is another case. It was a very complex CTO case, retrograde case. And we finished again with Protege DEB after, of course, preparing with the wedge and C balloon. And we sized up this balloon. We used only 2 balloons, 30 millimeter, and covered more than 120 millimeter lesion. So here is the end result. And next week, I will do the control angiography of this patient because it has been more than 8 months now. The patient is symptom-free. So this was a live case. It was a hell of a case. We did a triple access, and we had 2 stents and an osteal, 2 layers of stent in the osteum, in the left main LAD osteum, and we had also another stent coming from the Lima into the LAD. So it was very ambiguous for us where to start, where to go, but somehow we managed to go into the distal lumen, and we crushed the stent, the anastomosis stent with the microcatheter here. And we are in distal lumen. Here you can see we have also distal vessel disease after the CTO. And we prepped the lesion, we did IVUS, and we prepped the lesion with wedge and C balloons, and then finished the whole entire lesion with the Protege DEB balloon. And this is the last result. And there's always questions coming, you know. They say to me, okay, you are doing this, you are doing that. What about the follow-up angiography? So We are doing angiographic follow-up for our all comers treated with DEB in situ PCI. It's not easy to call a patient who become asymptomatic, and then offer an angiography for them. But we have some data in that sense. So this was another live case here. Again, it was a very complex retro case here. We had proximal dissection. Because of proximal dissection of the guiding catheter, we had to stent the proximal part, but the distal part was treated with a DEB. You can see here we have some kind of type B dissection at the distal part, and after 4 months you can see how nicely it has healed. So this is another case. We switch to a CTO procedure. What you are seeing there is not a stent, it's pure calcium. Okay, it's pure calcium. This was a rescue procedure, and we prepared the region with a wedge NC balloon, and afterwards with 4.5 NC balloon, Protege NC balloon, you can see the final result. And after 2 months, in this patient, this result is still acceptable to me. So this was another case, another CTO case here, and we finished with only DCB in the CTO part, and the proximal part was stented because of a catheter dissection. We need good support, and therefore we are using implants, and implants is very easily dissecting the proximal part. So we had to stent the proximal part, but the DEB, the CTO part was entirely treated with a DEB without standing. You can see the right ventricular branch and the distal part of the RCA, how it has enlarged after 2 months. So this is another case, very complex again. I'm going very fast here. So again, proximal part was standard, and the distal part was treated again with the DEB, and you can see the right ventricular branch after the treatment, and after I think this was also 5 or 6 months, you can see how the right ventricular branch has increased, and the distal part of the artery has also enlarged and healed. So this is another case for side branches. For side branch CTOs, this is a big diagonal here. And after treating it with drug-coated balloon, you see we have dissection. It's a type B dissection, and we left it like this. After 8 months, you can see how the vessel has enlarged, and you see the positive remodeling. And we are also doing QCA after the procedure and after the follow-up angiographies. And the minimal luminal diameter increased more than 50% in this case here. And this patient was also totally symptom-free. This is another patient here. We had, again, the CTO patient. The middle part was left dissected like this with a Protege DEB, and it was a type B or maybe type C dissection there, and we left it like this. And after 8 months, you can see how the vessel has grown, and we did the QCA, and the QCA showed also enlargement of the vessel and a reduction even in the minimal luminal diameter. So I'm coming to the end here. This was an ostial ambiguous RCA CTO, again, very complex. We had to go into the aorta and then snare the wire. It was in retrograde, very, very complex case. This was a very young patient with familial hyperlipidemia. And here you can see this was the result after putting a stent at the proximal part because there was extensive dissection, but the distal in-stent part was treated with DEB. And after 7 months, you can see even in the in-stent part, in the in-stent CTO part, the vessel has grown, and the right ventricular branch or a high takeoff TDA, it might be, you can see how the vessel has grown and healed itself after a time period. So again, the QCA has been made. And so the summary, I will conclude by rationalizing DCB in CTO PCI by we are preserving physiological properties. If you put a stent in a coronary artery, you create a stiff pipe, and you lose some physiological properties. The vasomotion properties are not there anymore. And positive vessel remodeling is evident with paclitaxel, as you have seen in my cases. And we also avoid metallic complications. If we have CTOs, that these are long lesions, and putting a long stent increases the instant restenosis and the complications rates. And another advantage using only DCB in CTO PCI, the shorter DEBT period is, I think, also an advantage. Thank you for your attention.
Thank you, Dr. Safkat. You've proved beyond doubt why we are big fans of your work, and you have such a big fan club around the world for your work. Amazing
Thank
work
you.
and amazing presentations. Professor Tsutsuli or Kastrati, do you have any words to add or comment on before we proceed with case 3, 4, and 5?
But I think that we should wait for the other presentations and just to leave the discussion at the end of the. In this way, we can discipline better our time.
Yeah, so I think then we will just accept that and go on to Professor Guillermo Sanchez, who is an interventional cardiologist at Navarra Hospital University in Spain. He's an expert in CTO and chip programs and treats very complex cases with DCBs. It's up to him for the next presentation. Professor Guillermo, please.
Good afternoon. Thank you very much. Do you hear me?
Yeah, we can hear you.
Okay. I'm going to, my case is also a CTO. I'm not going to repeat again something that has been explained before very well by our colleague.
Sorry to interrupt, Dr. Sanchez. Dr. Safkat, maybe you'll have to unshare your screen because otherwise you'll not be able to share the screen.
Yeah.
Thanks.
Okay, can you see my presentation now?
Yes.
Yes,
Okay.
you're good. Yeah.
Okay, now here we are. I'm going also to explain. We are, as it has been said, we're making a lot of PCI with only DCB because there are a lot of reasons, and we are having very good results with a good feedback that has already been explained. My case today is a male, 81 years old, with chronic kidney disease and diabetes mellitus. He also had a chronic venous insufficiency with venous ulcers and also the set of the digestive bleeding. He came with this exertional dyspnea, he had two, with ejection fraction of 45%, with an anterior scar with viability in the magnetic resonance. His creatinine was 1.5, and we have this an ejection fraction after the procedure with a mitral regurgitation significant, and on February we make the angiography. As you can see, he had a right coronary artery.
Excuse me, Dr. Sanchez, would you be able to put a presentation mode because you're still on the first slide? We're not able to see your presentation completely. You'll have to click on the broadcast slide. Yeah. Yeah. And now this shows your camera. We need your, now I can see you very clearly, but the slides are not seen.
Click to share. Do you see it now?
Yes, but I think you need to click on, there is the, wherever your slide is there, you have to click that part. You have to click on that, and then it will become a case presentation, because otherwise we're not seeing your slides. Yeah. It's not presenting.
Sorry.
You may have to put it on the slideshow, sir. Dr. Sanchez, you have to put it on the slideshow, sir.
I'm sharing, but it's not running. Don't you see the video?
We
Okay,
can't.
I know the problem. Let me give me a minute. I had two screens. Sorry, I am closing the big one. Do you see now?
Yeah, now you're good. It's the RCA-CTO video playing. Yep.
Okay. Okay, so I continue. Here we have the right coronary artery of this 81 years old male with comorbidities. He had this coronary, right coronary artery CTO. Can you see this now? Can you see the video, please?
Yes, we can see now.
Okay, this is a raw projection of the occlusion. It's in the mid segment of the right coronary artery. This is the left coronary with 90% lesion in the circumflex, big circumflex, with also a CTO in an LED. So this is the distal vessel, no lesions here. So we have an old male with frailty, comorbidities, CTO of right coronary artery and LAD with critical lesion also in the left circumflex. It was discussed in the HER team, and because of it was not so bad clinically with ejection fraction that was around 35-40%. He had no veins for cabbage, and because of the diabetes, we are not surgeons here don't like the double lima because of the problems with the sternotomy. So it was decided to make a conservative treatment. But 1 month later, we have a new admission for non-STEMI with anterior ischemia with a troponin of 2,300, and an angio PCI was decided as conservative treatment failed. The right coronary artery was the same, and we don't even see any difference between with the first angiogram. So we decided to treat LAD in a first procedure and leave the circumflex for a second one. The LAD CTO was short, tapered, and very calcified, but it was stressed. We went radial approach, EVU 4, and with a microcatheter, Corsair, and Fielder XTR, we couldn't pass. At the beginning, I had to change for an ultimate draw 3 wire. So I could cross the occlusion, and there was a lot of difficulty to cross with the microcatheter, but finally I could change for a high cell port guide here, testing the true lumen, distal true lumen, with a predilation with a 1.1 balloon. With a guideliner, I could pass a 1.0 balloon. This is the result, the initial result. Then change the rotor wire, rotablator with 1.5 millimeters solid. And this is the result of the rotablation. It's a hard lesion, calcified, proximal, but short. We make an IBUS always in these cases to adjust the size of the balloons, as it has been discussed, and to adapt the size of the stent if we decide for that. I predilate with a cutting balloon, 2.5, and with a 3 balloon. Then a scoring balloon, 3.5. This is a result with no small dissections at the lesion point, the proximal part. What do we do now? So it's a difficult case. We have a long lesion with a diabetic patient with digestive bleeding, pending for the second procedure to the circumflex. So we thought that we had to treat this lesion. We had to use a stem from the left main to the LAD, making more difficult the procedure to the circumflex. So we decided in this case to go for a DCB in the big de novo lesion. We used protegean C3.515 with this good result at the proximal LAD. Also, this case, not significant dissection, little bit of residual stenosis. But we had a next procedure for this patient. So in 2 months, we made a program PCI to the left circumflex. This was the LAD in the second procedure. As you can see, the flow is good. We have some residual stenosis. So we go straight to the left circumflex. We make a retulation with 1.5 leaf also, and predilate with an NC balloon 310, and with protege 310. Due to the good results, initial result with in the LAD, we tested the same for the left circumflex. So we had the result. So in this patient, frailty, old digestive bleeding, previous bleeding, we decided to leave it without this. And in the follow-up, 3 months later, he is asymptomatic with a mitral regurgitation that it's now 1/4, with a little better left ejection fraction at around 40%. So in this, this is a very we can discuss if you do for not stenting, but as we are making a lot of cases with DCB alone, we are confident about the results, and we are aggressive in the predilation. And if we don't have a good result, we have residual stenosis, important dissection, we put the stent. So now last year in 2024, we are now on 17% of DCB only PCI. There's some cases. I have 2 cases in our registry of restenosis. Not so much, not so different to the results with the stents we have, but I think this is a promising decision on the technology or strategy, let's say, that can help us not to put a stent that make more difficult to treat the side branch that in patients with diabetes, long lesions, that we have a higher rate of restenosis and thrombosis. If we have a good result with the DCB, it's important to be confident about living like that. Thank you.
Thank you, Dr. Guillermo. It was amazing to see that beautiful presentation and a beautiful result on the LAD and the circ. We will discuss further on how you prepared and what was done. We have 2 more cases. We had presentations from Europe, that is from Switzerland, from Turkey, and from Spain. We'll move to the other side. We'll move to the east. We have 2 presentations coming in from India. So let's go to Dr. Nitin Tiwari, who is a consultant interventional cardiologist at Wokhart Hospital in Nagpur, India. And let's see what he has to say about drug-eluting balloons and in his practice. Dr. Tiwari, over to you.
A very good evening to all of you. I hope I'm audible.
Yes, Dr. Tiwari, you're audible and your presentation is visible. You can go to.
It's a pleasure sharing the stage with such elite people and from all over the world and all the experts. So I'll briefly discuss about the metal-less PCI. What is the era of DEB? So we all know the interventional cardiology has evolved over a period of time, right from 1977 when this angioplasty was done for the first time, to BMS in 1988, to DES in 2003, and now leaving nothing behind. So what is the DCB? It's a conventional semi-compliant angioplasty balloon, we all know, covered with anti-proliferative drug, which is released into the vessel wall during inflation of the balloon. You obviously inflate it at a very nominal pressure because it's just a vehicle, and time can be 30 seconds to 60 seconds. And active substance on the DCB is lipophilic, so it is very easily absorbed through the vessel wall to compensate for the short period of contact. So ideal DCB should have an anti-proliferative drug. There should be least loss in circulation during the transition period. The tissue transfer efficiency should be very good. It should be lipophilic. Excipients should also be good, and the coating technique is also very important. And what is the initial dose and density, that has to also be looked at. So we know the major two drugs, the paclitaxel and sirolimus. Paclitaxel has irreversible binding, unlike sirolimus, which has reversible binding. And paclitaxel is lipophilic, unlike sirolimus, which is hydrophilic. And more importantly, both have anti-proliferative effects, but the anti-inflammatory action is more with paclitaxel as compared to sirolimus. And there is a moderate amount of positive remodeling also. That also is a very good thing. We all know this phase. So sirolimus acts on that phase, and paclitaxel acts on the M phase. Now, what are the criteria for DCB deployment? First of all, we should prepare the bed very well. A standard semi-compliant or non-compliant balloon or scoring balloon or cutting balloon, whatever we use, we have to use that. Then, if needed, in a very calcific vessel, rotablation or lithotripsy or rotatripsy or a cutting balloon, scoring balloon can be used. There should be no obviously very flow limiting dissection. The residual stenosis, if it is more than that, you can deploy the DEB. It is a very short delivery time and sufficient inflation time should be given. And if the criteria are not met, then obviously you'll have to go with the DES. What are the indications? As we have already discussed, ISR is one of the biggest indications: small vessels, diffuse disease, bifurcation lesions, de novo lesions, and patient with HBR. High bleeding risk patients also are very important. Next. So ISR, we all know 5 to 10% patients can develop IFR, and in such situation, if you put another metal, more metals, then it will be difficult because the normal physiology also will be hampered, and how much drug will be released, it's a big question mark. The patient might come back again. So DEB looks to be a very attractive strategy, so as to avoid intimal hyperplasia and dystenosis. And obviously there is an anti-inflammatory effect also in paclitaxel, so naturally the chances of the dystenosis also go down. As per the recommendations in ISR, it's a class 1 recommendation, class 1A. Next. So I'll briefly go through a few cases which I've done. In ISR, a 58-year-old gentleman, old inferior LMI, had double vessel disease, and PTCA to RCA was done with multiple stents in 2023. Now he had single vessel disease in 2024. So the ISR was there, and it was quite difficult. So first I used a cutting balloon, so as and the issues, so obviously we'll have to make the normal balloon, cutting balloon. Next. And then you can see I used 2.5 by 30 millimeter DEB at 14 atmospheres for 60 seconds, and then another 3.5 by 40. Next. And you can see, I think, the reasonably good result which you could achieve with this patient. Small vessels are very, very notorious for rupture, for restenosis, for passage of the stent also, and the restenosis rates are very high. So DEB appears to be a very, very attractive strategy in this situation. Next. And there are various trials which will not go into details, Pico, Leto, Bello, and various other basket small. They've all shown reasonably good results with DCB. So coming to the case, a 54-year-old gentleman with an entry-level MI, EF 36% TVD, primary PTCA to LD was done with DES. Next. You can see. So this was a very diffuse kind of disease. So if we'd have put a stent, I believe he would have definitely come back with a restenosis. So I think 40 millimeter DEB was the idea. I see the fang result. Next. DEB in the lesion in PDA small vessels, as I have discussed. I agree that the pre-dilatation balloon did not get dilated that well. So then there was no effect. So still dilation was opened by a DEB after after proper dilatation. After a cutting balloon mostly I used a DEB, and you can see I think this lesion which was not opening up has opened up well, and we could save the PLV branch also. Otherwise, had I put a stent, I think then I would have needed to be do a bifurcation at this small vessels, and it would have ruptured or something. So DEB was a good option in this also. Coming to the indication 3, bifurcation. I think for DEB in bifurcations, we all know multiple stents. If you use the restenosis chances, especially the side branch, they go up very artery for a restenosis. And so generally we use the DES in the main branch and a DCB in the side branch. Now this case, 67-year-old gentleman had cardiac arrest also. He was revived. He had left main with TVD, and 2 years back RCA PTCA was done, and his graft got occluded. So in fact, venous graft got occluded previously 2 years back. So he was stented somewhere else at some other center. The stent was doing well for the RCA. He came to me with unstable angina and minimal at NYHA class 4 symptoms. So he had poor LV also. Next. So when I could see, you can see the graft got so this is the Lima to LED graft, and there was a Lima to Y graft put. The LRA was given to the circumflex, to the OM. So this was not flowing that well. I dilated with the DEB. Now you can see it's flowing well. Again in side branch, a 2.25 by 25 DEB. It's doing good. Next. And de novo lesions can also be at times used, especially when you don't want to give DAPT for a longer period, or as has been discussed, like in patients where, and we again have, a gamut of trials which have shown that DCB can be as a bypass graft intervention. This was that case I was talking about actually. So this patient had 3 grafts, Lima to LED, and that Y graft was from the LRA to PDA, which was a Y graft from the Lima. And his angioplasty to RCA was done elsewhere, did somewhere else. Now he came to me with the Lima was flowing well, but the OM, the graft had totally occluded, and crossing this wire was a very, very difficult job, going from the Lima. In fact, at that time, we did not have the EMA catheter also. So what I did was I shortened the catheter. I took a 7 French guide, and then I put a 6 French inside it and made a hybrid catheter, and then entered that. But by making that, obviously, it's not a a factory thing. It's a man-made thing, manual thing. So I was worried whether the stent will be dislodged while putting, because in fact I did the angioplasty of the catheter itself first with a 3 mm balloon. I just dilated it so that it becomes smooth. But still, so after wiring, it was very difficult for me to pass because it was a man-made catheter. It was not a factory-made catheter. So I decided that I will not put the stent because the stent might get dislodged. So I decided to use DEB. My intention was to use a longer DEB, but considering the constraints and considering the angles and all, it was not crossing. So I used a small, 3 different DEBs in this patient, as you can see, 3/10, 3/15, and 3/20. 3 DEBs I used, small, because it was very, very calcific and it was very difficult for me to pass. Next. Then you can see this gratifying result. I think it was a very good result, and the patient was absolutely asymptomatic. The ejection fraction also improved, and his symptoms and the LV can see in this
Dr. Tiwari, sorry to
improved.
Dr. Tiwari, sorry to interrupt you in between, but there is an
Also very young.
sorry to interrupt you in between, but there is an internet lag issue from your side. Maybe you can switch off your camera so that we can. Otherwise, there is a voice interruption. Yes, thank you.
So now can you hear me properly?
Yeah, we can hear you properly now.
Yeah, so this young patient with high thrombus burden came to me, 29-year-old gentleman with acute inferior VLMI for a primary angioplasty. Ejection fraction 45%. Next. Next slide. Yeah, I'm sorry for that problem. You can see the thrombus burden was very high, and in India is very common. LED is more commonly involved, and it's a very high thrombus burden. So I did a lot of thrombosuction, 3 or 4 run of thrombosuction was done, and you can see the vessel was healthy, but I think it was just thrombotic. Next. So after that, after pre-dilatation, I used a 4/30 millimeter D.
I guess, Dr. Tiwari, we're having severe
Yes, we
problems
have.
with your internet. Maybe this would probably be the last slide if we can accept this, because we are losing on time.
We can't hear you. Yeah.
Next. Although there was some minimal thrombus, but to be 3 inhibitors, and he was absolute. And where not to use is high ischemic risk, large vessels, and calcific complicated vessels. Thank you.
Right, so that was the last slide. We did see most of the presentation. We move on without losing much time to the 5th presenter, that is Dr. Srikant Shetty, who is the director and Head of Department of Cardiology at Sakra World Hospital in Bangalore. Dr. Shetty is one of the top cardiologists of Bangalore and mainly has an interest in CTO PCI.
You were able to see the cases at least?
Yeah, we were able to get the cases. We saw most of it. We'll leave the discussion for the end. Thank you, Doctor. Dr. Srikanth, the stage is all yours.
Good evening, everybody, and I'm glad to be part of this meeting so we could get fantastic insights into use of drug-coated balloons in complex situations. Are you able to see my slide?
Yes. Go to
Yes,
presentation mode, please.
So please put it on, yeah.
Actually, it is in the presentation mode here, so maybe I'll close it once and then...
You probably have two screens open, so that's the reason this is showing. So you need to go to the bottom.
And I lost my presentation, Eric.
Well, we'll wait for you for a few minutes, or while you get it ready, probably I can ask.
Yeah, the next presenter.
There's no, you're the last, so
I'm the
I will
last.
ask. So
okay, is my case seen now?
Not, we can see you, not the presentation. So
1 minute, just give me a minute. Is it visible?
yes, only your thing. Yeah, see, this is the problem. I think you have two screens. Your computer has two screens. That's the reason it's showing like this.
Okay. Can I take some help here?
Nancy, is there someone from tech
Sir,
who can?
Sir, we will tell our broadcasters to do it. In the meantime, sir, if you can close that presentation, and then, sir, once again open it and then select it, do the process. Sometime it works. If you can do that way, sir, please do. Close the presentation, and then and then open it and then select it. It will work better. In the meantime, Nancy would connect with our presenters and maybe with our broadcaster team, and they will do the from studio.
In the meantime, while we have the time, I would ask the chairpersons, Dr. Kastrati and Dr. Susuli. Dr. Kastrati, your comments on how the process of angioplasty has kind of evolved over time, because when we started angioplasty, we are dead scared to leave a dissection. We go and put a stent. From there, we've gone to putting a BMS there. Then it became a DES. Now it's become a drug-eluting balloon, and then we leave the dissection as it is. So it's pretty scary for people who started 20 years ago like us. When we see a dissection, we stent it. And now we are now leaving bigger and bigger and bigger dissections back. And then we are very proud of it as well. Your comments, please, sir.
So thank you, Dr. Georgiou, and thank you also for the great moderation of this session. I thank very much the speakers for their great cases, and they illustrated their high expertise in dealing with complex situations. So we focused on two issues, on two aspects today. One is the DCB only PCI of de novo lesions, and the other one is the uniqueness of the Protégé DCB. And my questions have to do with these two aspects, and I want to ask the panel and the speakers to have two short answers for my questions. So if you look at the consensus documents on DCB, you see that they are recommending switching to stent in the cases in which there is flow-limiting dissections, residual stenosis more than 30%, and FFR result under 0.8. My first question is to do we need in this case, because you don't see here, the role of intravascular imaging. On the basis of this document or on the basis of their own experience, I'm asking the panel and the speakers, do we need intravascular imaging to guide our decision to switch to stent in these cases? And let's start with Dr. Pai, for example. He was very quiet during this session, and I want to know his opinion. Is he using intravascular imaging for taking decisions when to switch to stent after balloon, after lesion preparation?
Thank you
Sorry
for.
to disturb, sir.
Can you hear me? Yeah, can you hear me?
Yes.
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 I'm from the technical team. Sorry to disturb.
Thank you for is an interesting question from the Professor Castri. In my practice, when you use the angio guide, you can see about the dissection. It's only A on B, but when you use the imaging or guiding for I use IVUS, you can find out more serious or dissection. So you only don't care about to change the DCB to DS, but our practice, I only focus on angiography. If the dissection only A on B, the floating or 3, I keep the DCB. But when I only use IVUS or imaging technique for prepare the lesion before the PCI or deciding, when I estimate the lumen of the length of the lesion. So, and after I use the P-dilatation, I don't use it imagine for to switch from the DCB to DES, because I use it, I first you only you keep the change from DCB to DS, because you see the more serious dissection, you afraid of acute close. So I use an angio guide.
Dr. Kumar, what is your opinion about the same question?
Pramod, you are muted.
You are muted.
Hello, thank you, and a very good evening to all of you. So I've practiced the same thing. I use IVUS for selecting the lesion and preparing the lesion. And once I have put the drug-coated balloon, then I don't use it. I just, totally depend on the angiographic pictures to decide whether something more needs to be done or not.
Dr. Dani? Samir, are you
Dr.
there?
Samir, are you there?
So let's move to the speakers. Shefkat, what do you think about the role of intravascular imaging at the end of lesion preparation?
So IVUS helps me only to understand how further I can stretch the artery. I use IVUS only to understand whether I should use scoring balloons or cutting balloons, or whether what kind of diameter it should be. Otherwise, to decide whether I should stent or not, IVUS is not the referee here for me.
Okay, let's move to the second aspect and my second question. So we have been using the conventional. Yeah, please.
Let me protect imaging. Now everyone that they're using. So I am a big fan of imaging, and the more difficult the lesion is, the more imaging we need. If it's a simple lesion, you can, like in the stent world, but to claim nowadays that you can do a highly complex lesions without imaging, yes, you can do it. Can you do it with the same quality in long term? Probably not. I think if it's true for stents, and we have now a 1A recommendation, then it's probably also true for drug-coated balloons.
No.
Thank you.
Florim, I was thinking about the decision to move to stent, not for the use of intravascular imaging for lesion preparation at the beginning. For sure, I am for using for intravascular imaging at the beginning, during lesion preparation, to guide lesion preparation. But the question was, do we need it at the end to decide whether to leave a stent-free PCI or to move to stent?
Well, the problem is that nobody knows that answer. And I would, for example, claim that if I have luminal gain, which I can see, and if I have a certain dissection type, which I know is associated with luminal gain, from my experience, then I have developed an algorithm for myself and for my center. But we don't have a commonly recognized algorithm for, recognized internationally. And that's the problem. What is written in the consensus document is, in my opinion, useless. That document is really not helpful in your daily life, because it states you can do anything you want.
I would like to have one more comment, if we have time. So I understand what Florim is saying, and I totally agree. And I was imaging, or OCT is essential in preparing for DEB to understand the anatomy. But we will understand only after the accumulation of some data what kind of lesions we can leave like that or not. That's the reason why we're trying to understand with our only DCB strategy in CTO PCI which kind of lesions we can leave. But CTO is a different animal than a lesion. And we have you have a residual maybe lesion around 50%, which is in CTO PCI for us acceptable. We can leave it with the drug-coated balloon as long as we have TB3 flow, because the artery will heal itself with time. But which lesions we will not be able to see open in the future will be decided after accumulating all the data and then running maybe a multivariate analysis according to lesion, entities, the lesion properties. But for now, we can only talk about our experience. So I totally agree with Florim about that.
Okay. Yeah, thank you. So my second question has to do with the kind and type of DCB. So we have been using for 15 years conventional DCBs. And my question is for the panel and for the speakers, have they been concerned with the drug loss before balloon delivery? Yes or no?
Yes.
So let's go through. Dr. Tai?
Mr. Kasrati, Dr. Sanchez wanted to say something.
Yes,
Dr. Kasrati.
Yeah, please.
Sorry for the interruption. Just to make another comment about the question you made before. We are imaging lovers. We were doing 29% of imaging in 29% of PCI. We're making intracoronary imaging. And I think the point with the IBUS, I of course agree about the preparation of the lesion more and more when the lesion is more complex. But for the result, I think the point is the IBUS is good for the residual stenosis, not for dissection. I agree with my colleagues that it is that the angio is sufficient for deciding about the dissection. If it's a dissection that is getting bigger or longer.
Yeah.
But the problem is that I saw that with some cases of failed treatment of the lesion with DCB when you are more conservative about the predilection and the result you want when you're using DCB because you're afraid of the dissection. So the problem, because if you see an important dissection, you see it by angiogram, okay, and you put the stent. The problem is you are a little bit more conservative with the predilection, the lesion, or with the size of the DCB, and then you have residual stenosis that perhaps if in a proximal, we are speaking about big de novo lesions, you can leave the patient with similar ischemia. So we are making emphasis on calculating the residual stenosis with IBUS, but not for dissection, for the residual stenosis.
Okay, thank you. And for the second question, Dr. Tai, what do you think? Have you been concerned with drug loss so far or not?
Of course, I always concerned about the loss of drugs. In our practice, the prepare the lesion is very important, especially is the distally of the lesion. I only to prepare very well before I deliver the DCB. That is very important. In the complex case, for example, the angulation or severe calcify, I use the rotation first, and eventually I use the guiding extension and to push the DCB as a distal lesion to protect of the drug delivery.
Yeah,
Thank you.
that's very right. It's clear. My question has to do also, do we need a change in the balloon technology as it is offered by Protégé just to protect against drug loss during
Yes, I
balloon
think
delivery?
I agree. I think yes, most of my cases, around 80 to 90% of my cases, that's not a problem. But at times, you are worried about whether you are losing the drug. It's your heart is racing, whether you will be losing the drug, whether you are doing the right thing. So
The
if the drug
tradition.
is hidden in the way Protégé has done, I think that
Yeah.
gives me more confidence to use it, and I feel more secure that yes, at least I am placing the drug at the right place. So I definitely feel
So
there is a need for such
traditionally,
kind of technology.
And I think
Georgi, what do you think?
so traditionally we had the drug-coated balloons with, a sugar coating on the balloon, we used to call it. And we worried about the time transit from the Y connector to the vessel. And if the vessel has calcium on the way, you would be,
Sure.
coating
Yeah.
everything out. And we are very worried that it would not reach the vessel. With the Protégé, which folds all the thing, they actually say unless you dilate the balloon and unless the vessel is in contact with pressure on the balloon, the drug is not eluted, which kind of is good because according to this, almost 100% of the drug, or let's not say 100, at least 90% of what we want to do reaches the lesions. And another thing that Protégé has gone with is, you can inflate the balloon 3 times in the same vessel or in the same lesion. And they have an elution characteristic where 25 micrograms or 10 to 25 micrograms is delivered to the vessel at the first inflation. And if you phase it out as 30-30 or 20 seconds of elution, then you can, up to the third time of inflation, you still have drug available for elution into the vessel. So it's actually a very innovative and novel way of doing it. And of course, another big problem we had with the previous drug-eluting balloons is pushability. We couldn't get it through the vessels. And that, as Dr. Sevket has kindly shown us, amazing places where he's pushed these balloons. In my experience as well, it has been that these are beautiful balloons to push, and the deliverability is not affected by pushing things through these difficult vessels. I guess, the way this is constructed, it has brought a big change to our practice. Now, if I'm not interrupting much, there are a few questions from the audience as well that have been put up on this thing. So I will pose them to you because we're running short of time. We're almost past our time, but it's been a lovely discussion so far.
Georgie, just one point. Sorry, Georgie, just
Yeah.
one point regarding the drug. I think one phenomenon which we did not mention is the distal embolization of drug, which for some of these balloons is a major problem because you don't
Yes.
want to have the patient coming in with stable angina and going out with a STEMI. And you can have STEMIs with some sign. I was doing a live case at Toby and it was a beautiful result until we had distal embolization with the balloon, and then it ended up having a STEMI. So I think
And no flow distally.
yeah. Okay, let's take the questions.
Okay.
So the questions are, the first question was why paclitaxel over sirolimus? I think Dr. Tiwari answered that question in one of his slides. Minimum drug loss means more absorption of paclitaxel. How do we deal with this? Will it cause trouble if you give more paclitaxel to the vessel as compared to less paclitaxel?
Well, so
Anyone
far,
taking that?
so far, there is no indication. We treat now hundreds of patients. We have a lot of follow-up of these patients, and we don't see aneurysm formation or anything wrong going with it. So, and I don't see a sign. Does anyone see a sign that paclitaxel could be a bad thing?
Anyone seen any?
Not for the DCB. Maybe
Not
for
for
the
DCB,
stent,
exactly.
but
Yeah,
not for
right.
DCB.
Probably we saw more with the cipher stent producing aneurysms than any of these recent stents or DCBs for that matter. Okay, how can clinicians adopt a tailored approach with DCBs and coronary interventions? Is there an algorithm or a criteria to guide selection of the most appropriate devices and in the different clinical scenarios?
The question is for what devices, Georgi?
This is for the DCBs. Like, is there an algorithm on which we can tailor how to approach a lesion? Like, all of us are experienced operators and we can push things through. But for a new operator, is there a guideline or is there a algorithmic approach that we can do so that they can use these new balloons with ease or take the right decisions rather?
Shefkat?
Oh, this is a very hard question. So in CTO PCI, we don't have any algorithm because I think the only DCB approach in CTO PCI has been going on, only to my knowledge, with 3 or 4 operators we are doing this. And so we don't have any algorithm, and we are waiting for the control angiographies. Maybe we can create one. But for the other lesions, I think you or Florim would answer that better than me.
No, I would ask also Dr. Dani because I saw that he's
Oh, he's
present
finally
now.
online? Yeah, okay.
Yeah. Dr. Dani? Have you got the question?
If I understand, my apologies first of all for disappearing in between. If I understand the question correctly, the algorithm for selecting the patient for DCB, is that what?
Yeah. Is there any specific algorithm that we can?
What we do in our setup is those patients who are not likely to do well with another stent, with a stent in the lesion, like small vessel, or you have a bifurcation where there is a branch vessel which is not very great in size, or there is a ISR. So these are, or where there is high bleeding risk. So these are the patients, group of patients who are not likely to be doing well with stent, where you have some trepidation or some reservations about putting in stent. And the other group is where there is a possibility of stenting, but we choose DCB over stenting. In those, these are the patients who are multi-vessel lesions, multi-lesions, or very long diffuse disease. These are the patients where we choose a combination of DES and DCB. Like proximal vessel, we have DES, and then distal vessel, we go for DCB, or select LAD, proximal LAD, you select the stent, but you go for a circumflex which is non-dominant, where you go with DCB, things like that. So that is the kind of algorithm we follow, that when there are multiple stents we want to avoid, and when there are stents where we want to avoid stent altogether, these are the cases we choose for this.
Another question that we have been polled of is in lesion preparation, opium balloon versus cutting balloon. Which is the better thing to do, or how do we choose opium versus cutting?
Florim?
Yeah, I mean, I try to show it in my case. I think if you have a heavily calcified lesion, then the cutting balloon itself will actually not do the work. If you have a calcium ring, you need to crack the ring. You can crack the ring with an opium balloon, as I do it. You can crack it with IVL, but anything else, usually, if an NC balloon does not yield, then this is the area for open or IVL. Or some ablative therapy. However, the cutting balloon is a fantastic device for fibrotic lesions, which is very often the case. How do you discover a fibrotic lesion if you don't use imaging? You inflate an NC balloon, the balloon opens, you deflate, and you have still the same diameter stenosis. The lesion is fibrotic, use a cutting balloon. So this is the easy way to test it. And if it's a fibrotic lesion, then the cutting balloon is a fantastic device.
Okay, I think that we agree with what Florim said. Let's move on. Do you have any other questions? Or?
We have a lot of questions. What is the optimal antiplatelet strategy after you use a DEB? And would you consider using low molecular weight heparins for some time because you're leaving dissections, possible thrombosis in the vessels after treating them extensively from end to end with DBs? Who wants to take that?
This is a very important point. I think this is really, maybe we should take 3-4 minutes to discuss this, because usually, let me start with this, because I do a lot of imaging, and with imaging, you get the sense that if you do extensive treatment of a patient who is maybe not on antiplatelet therapy already, so he's coming with no aspirin, no clopidogrel, and you start to treat him, you will see that with time, you will see thrombus developing in the vessel, despite the fact that you have given heparin. So in those cases, I tend to give a bit more heparin as they leave the cath lab, because I'm afraid of acute thrombosis, and we have had mild thrombotic events in such patients after the procedure. So I think in patients who are on DAPT, then usually you can work quite freely and you don't need that. However, if they are native on antiplatelet therapy, naive on antiplatelet therapy, I believe that we should give more heparin, but not give it as a bolus in the beginning, but give it, just as
for how long?
Procedure
for how long?
Yeah.
For how long would we keep adapt? For how long would we keep?
In our lab, it's for stable disease 1 month, for ACS 12 months.
No, I mean heparin infusion.
So we don't give an infusion. I would usually give them a bolus of 2,000 to 3,000 once I finish the procedure.
Okay.
Okay, and yeah. So what we've gained from the preparation so far is presenter number 5, Dr. Shetty. Is he ready, or we will have to, close soon?
Mr. Shetty, your slides are with us. Your slides are with us. If you want, we can run for you.
No, I think we are having a good discussion. Maybe we can continue with the discussion.
We can still complete your presentation, and then we can take up the discussion after that. Most of it is done anyways.
If you go quickly.
Yeah, for sure. If I think they are going to show the slides.
You can run it first.
Yeah, you just
Nancy can run it first. Yeah. Sir will give a quick. I think he had done a lot of hard work preparing this presentation. We need to have it, sir. Sorry for the challenges. It so happens sometimes technical glitch are beyond our control.
Sometimes CTOs is easier than PowerPoints, isn't it?
Yeah, I know. It was so embarrassing. I'm really sorry. And these are 2 simple cases. I mean, I think the concepts around these cases have already been discussed through this session. So this is a young gentleman, 48-year-old, diabetic, controlled on diet and lifestyle alone. He came with an acute inferior MI with a small regional wall motion abnormality, and EF was good, 50%. Next slide, please. Next slide. Yeah. So as you can see, there is a distal RCA, there's a tight thrombotic lesion, and the entire vessel is minimally plaquey, extending into the PLV as well. So the thought on our mind was, should we treat it like how we typically treat it, with clot aspiration followed by predilatation and stent, or should we do a drug-coated balloon strategy? The left side, there is some moderate disease in the circumflex, and the LED was good. Next slide, please. Next slide. So we did predilatation, and there is still some residual, so we also used a 3 millimeter cutting balloon there. We dilated all the way into the PLV, and then because there was diffuse disease, and then it would be difficult to find a healthy landing zone behind as well as distally, we did a 2.5 by 35 DEB in the PLV, and then a 3.5 by 30 millimeter DEB in the distal RCA. Next slide. And I think we got a good result over here. There is some spasm of the ostial PDA which will be relieved. So there was some discussion about whether you give low molecular weight heparin post these procedures. all our DCB patients, we discharge them with an advice on dual antiplatelets along with fondaparinux, which is easier to take at home for about a duration of 5 days. Similarly, we send this patient also on fondaparinux. And this second patient, stable angina, diabetes, dyslipidemia, and normal LV function. He had single vessel disease. Next slide, please. He has proximal to, mid to distal LAD diffuse stenosis after a large diagonal. So in this case, I felt stenting all the way down and metallizing the LAD would close long-term options for him. So we have to imagine lifetime management of coronary artery disease for our patients who are relatively young, and metallizing the artery, which in areas which are potential future bypass graft targets would limit their options. So in this patient, next slide, please. So we did good lesion preparation with first with 2.5 NC balloon, and then with 2.5 and 3 millimeter Wolverine cutting balloon, and we had good dilatation of the lesion. And next slide, please. We followed this up with 3 by 38 DES in the proximal mid LAD, and after post dilating, next slide, we did a 2.5 by 35 DEV in the mid and distal LAD, after which we got this result, which looks very good. Next slide. So there was no residual stenosis or dissection, and I think this is a good long-term strategy for this patient with diffuse LAD stenosis. And thank you, and apologies again for the technical glitch.
It's okay. CTUs are easier. I understand. No problem. So that was beautiful 2 cases, Dr. Shetty. We go back to the question and answers that we were doing. Any thoughts on bioabsorbable scaffolds, since we're on the topic of this, because there was a magnesium stent that was shown to be absorbed and then it would go away. So since we are on the topic of leaving nothing behind, are there any thoughts on bioabsorbable stents? Of course, they absorb and those fellows are out, but we do still have a metallic stent which can be absorbed. Any thoughts on these? Has anybody been used?
Yeah, well, we have actually quite a good experience in Lucerne. So with Absorb, our experience was actually better than with magnesium-based stents. So Magmaris was not that successful in our lab as we expected it to be, and we have a publication with quite a bit of bad events at 5 years with Magmaris. However, the new generation Dreams, I don't know how good it is. I don't use it. I just recently started.
Yeah.
Sorry?
Yeah, we haven't seen much of the newer ones. There's one called Free Solve, again with magnesium, smaller struts and stuff. So
I just started using Phantom, which is a new device. I think in the future, wherever I can use a DCB, I will use a DCB. I think in very proximal vessels, large vessels, not a long diameter, metallic stents are probably still first choice. And then there is maybe a really an in-between segment for scaffolds. I think scaffolds will be a niche product for the next years and not overtake the space like DCB has done. So I think yeah.
I think that with the broader use of DCB for de novo lesions, there will be less room for bioabsorbable stents.
So that also may not be a long-term trend, because it might actually go down with more success with the DCBs. Also, there's an interesting question that has come up. Are there any legal concerns with leaving behind a dissection or an elastic recoil? Are there any legal concerns? Can we get into trouble with the law?
I mean, this is. I'm sorry for saying this, but I think this is a very important point. So I have gone so far that I consent my patients for DCB before I start the procedure. So when they present in our lab, or even in the outpatient clinic, we tell them that we might be using DCB as well as stents, and so far this has proven right because the patients are informed, they know about it. I think using an off-label device, using the device in an off-label setting like proximal AD and then having a thrombosis could be really a legal problem. What does the round think about it? Who is worried as well?
Well, I about this, my concern, the thing is that most of the events you can have with the DCB, I mean, are going to happen in the hospital. We are not very comfortable about our patient going home the same day of the PCI when we use a DCB only strategy. We leave them at the hospital until the day after, but for the discharge. We are more conservative. When we make DCB, we make more comprobations. We take the wire and then test again with the angio that the dissection are not growing. And I feel comfortable about this because we are speak with the patients. I explained that they have a very low probability of stent thrombosis. We put a stent in some trial we are making. In the Copernican trial we are making with the primary PCI with the DCB versus stent. I explained the patients, and they have, and it's true, a very low probability of stent, very late stent thrombosis, but it's very lethal. With high mortality, and we have some events we haven't until yet, but it's probably in the lab or in the hospital. So I feel comfortable about this, but you have to explain the patient there.
Okay, so are there any more questions that the chairpersons have? Dr. Kastrati, do you have any more comments to make?
No.
Any of the other experts that we have?
Dr. Tiwari, just a question to the panel that, at times it happens that after a proper pre-dilatation and after all the imaging, you do and then you end up with some dissection.
Unfortunately, Dr. Tiwari,
again, Dr. Tiwari, you can write the question as a message.
Eventually, you'll have to put a stent. It's a flow limiting dissection. So
Dr.
we are
Tiwari,
giving a double dose of.
Dr. Tiwari, sorry to interrupt, but we are not able to hear you well. You can write your question in the chat box.
Now
we have.
Am I? I'm sorry.
You're audible now.
If you can quickly mention, because you were audible for some time, now you're not audible at all.
May I ask Dr. Kastrati and others, I attended a presentation by Dr. Alok Finn, who showed that with paclitaxel coated balloons, sometimes there are crystals from paclitaxel which embolize to the distal vessel, and they get lodged into the distal tissue. Whether that has any clinical relevance or not, that has never been studied. But are you worried about such phenomenon, or do you see such things in your practice?
I think that Dr. Chuchuli answered this question with cases. I think that this might be a problem treating long lesions with long balloons or several balloons. We have looked at this issue in our study, but it was in-stent restenosis. We looked at the troponin elevation after the procedure. We couldn't find a difference between DCB, plain balloon, and stent in our randomized study. This is the only published study in a randomized way. but I think that might be different, treating de novo lesions, long lesions, complex lesions.
And
I have a question.
And it's important that not all balloons are the same. So I will not mention all the names, but I have taken out 2 balloons out of the shelf, which were good balloons, but they were embolizing too much. So not all balloons. However, I think now with Protégé, I haven't seen a single case with distal embolization. And I think the reason is because the drug is not is not on the surface, but it's really you deliver it as you open the balloon and push it to the wall. So maybe you loosen the drug on the other balloons as you go up, and then when you inflate it, you embolize. I think this is probably really related to certain type of balloons.
Yes, Dr. Shetty.
So in difficult to deliver situations, like you taking the balloon up along with parallel wires or through a guide extension catheter, do you think interaction of the balloon surface with these devices or the extra wire causes a higher loss of the coated drug, if not with Protege, with the other balloons?
Shall I take that question? I think all the presentations that were given so far, there were some rules that we always prepare the lesion properly first. We try to avoid friction. We try to make it as easy as possible to take and deliver the balloons. In difficult to deliver, you have to anticipate that it's going to be difficult to deliver. Therefore, you prepare the lesions with cutting balloon, with scoring balloon, with IVL, with rota, with whatever it is that you can make it easy to deliver the equipment where you want to deliver it. So,
Georgi, it might be a problem for bifurcations, for example, for kissing balloons, etc., in which you cannot avoid the presence of another device in the vessel. And that's why we need some different balloon. And this might be the role of Protégé.
Because of its different construction, you will not peel off the drug from the balloon. So
it is the other devices are not in contact with the drug.
Yep.
And
so, Dr. Tiwari's question, I'll just put up Dr. Tiwari's question, which he was lost in concern. So, are there any concerns with the double dose of paclitaxel and sirolimus? Because sometimes you might stent a paclitaxel treated lesion because of dissection. You might stent it with a DES. Is there a concern if you use both these things together in one spot?
I don't think that it will be an issue, and there are even more frequent use of the combination of stents, drug-eluting stents, and DCB. If you hear, for example, Antonio Colombo, he's using the combination in different complex situations with a high risk of restenosis. That means at the beginning, if we go back to the history of drug-coated balloon, it was a contraindication to use a drug-eluting stent with DCB. And in all those cases, you had to put a bare metal stent and not a drug-eluting stent. But we are far away from this concern.
That's all history. That's all history now. Well, we've come to an end of a 2-hour session, which was supposed to be 90 minutes. Now it's become 120 minutes. So we still can go on and on. There are a lot of things that we can discuss. I will just summarize quickly from what I have seen and heard so far. Take-home message for all of us. We are attempting uglier lesions, longer lesions, crazier lesions. We are all becoming smarter and more complex. We don't know where it ends. Number one, image, image, image. If you can image it with whatever you have. Image is one of the most important things that you can get away from trouble so that you can get a final good result. Number two, lesion preparations. Preparation with whatever you have. Whether you have an OPN, cutting, scoring balloon, or a rotablator or a CSI, whichever you use, you have to prepare your lesions well. On that note, we have to remember that the Eclipse trial actually said, whether you use a rota or a CSI or an OPN balloon, all that mattered was actually dilating the calcium to the level that you can get an optimal lumen size. So lesion preparation is paramount so that you don't leave an unprepared lesion and try to get into that with a DEB. We know that we have a good drug-eluting balloon in Protege, which is not going to deliver the stent in the catheter or in the proximal vessel. Rather, it's going to deliver it at the point where we choose. So that's something new about the balloon, and it's a very trackable balloon. Antiplatelet strategy, most of us would use 1 month of DAPT. Some of us would use a little bit of heparin in the first few days or the time the patient exits the cath lab, but not more than 1 month. We don't have much of complications as of now. We are frequently using drug-eluting balloons in CTO PCI, and Dr. Sevket actually uses it entirely and doesn't use stents anymore. So we've come the full circle from the plain POBA, POBA, where we started, where we started angioplasty years ago, and we've moved from stents to coated stents to no stents. So as of now, no more stents is what we are kind of looking at. With that, gentlemen, it has been a lovely evening. Have a lovely rest of the evening to all of you. Thank you so much.
Thank you. Thank you very much.
Thank you so much.
Bye
Good
bye.
evening to
Bye bye.
everyone.
Bye bye.